All right, we're going to start because we want to try and make this session interactive. We want to keep it on time. I wanted to thank you all for getting up this early in the morning and to welcome you to the Diabetes Care Symposium. This is an annual symposium that the Diabetes Care leadership gets to put together at the invitation of the Scientific Sessions Planning Committee. And this year we decided to talk about how do we fix a broken healthcare system. And a little bit contrary to the normal plan, I'm going to actually show a couple of slides before I introduce the first speaker. All right, so this slide here just looks at the relationship between gross domestic product per capita and health consumption spending per capita in 2023. And I highlight there in green the United States, where the average income is about $82,500 and health spending is $13,000. So that's the green. The line underneath it represents the average for a number of countries, and I've highlighted a few of them, some clearly above the line and some of them below the line. And what's really interesting is that when you then take these data in terms of cost per person and look at the quality of healthcare we get, you can see here that the United States is ranked 15th in the world, right? And Taiwan at the top is ranked at the top, and there are only 111 countries ranked. So we're really far down for the cost of what it is to look after people. And one of the things that drives some of this cost is medications, which is going to also be a focus of today's talk. You can see here 5 different medications that are in the top 13 different drugs and what's spent on them annually in this country, with the total expenditure being $805 billion, and you can see that the 2 GLP-1 related drugs themselves are using $85 billion currently, and that's continuing to grow, as you can see in the column on the right. Now, clearly this poses questions, and it's very interesting that one of the people who thought this is a problem is the HHS's secretary, who seems to be in the process slowly of destroying everything else about healthcare. He says, quote, at a Senate hearing just over a month ago, clearly something is structurally and systematically wrong with this system. Furthermore, healthcare costs are steadily increasing at a rate of 2% greater than the economy. And what is of serious concern to us here, and it will include one of the speakers, it is a discussion of what appears on the next slide. This is the proposed 2026 budget for the Department of Health and Human Services. And you can see here that the cuts that are proposed for NIH is $18 billion, or 40% of its current budget. And this goes with the CDC cuts of approximately the same in terms of percentage, and AHRQ of 35%. These are all the places that we need activity. Some of us who are funded by these agencies, and others of us who use the output from the research done by these agencies ultimately to improve patient care. So this is what we're looking at. This is what we're confronting, and this is why the leadership decided that it was time to do a symposium on this. And I'm really pleased to say that we have a quality panel that I know you're all going to enjoy hearing from. First, Seth Berkowitz from UNC will talk about comprehensive view to improving healthcare for Americans. Mariana Sokol will then talk about pricing of medications. Marshall Chin on value-based payment and alternative payment models. And then Nami Kandula on social drivers of health. And then we also have Congresswoman Kim Schreier, who we'll get to introduce later, who's going to talk about the funding of research and disease surveillance. I will also mention to you that these speakers, as part of the contract with them, have to write manuscripts, and those manuscripts, some of them are already online. And once the print edition of Diabetes Cares comes out with them, for those of your friends who were really impressed by this, you were really impressed by the symposium and want to hear it, the whole symposium will be available as a video from the table of contents of Diabetes Care Online once the print issue comes out. And with that, I will introduce the first speaker, who's Seth Berkowitz from UNC. He's an associate professor of medicine, director of research in the Division of General Medicine and Epidemiology, whose work is really focused around social drivers of healthcare, and he's going to speak to us about the comprehensive view to improving healthcare for Americans. Seth?
Well, thanks for the very kind introduction. Thanks for folks showing up early in the morning. And so as Dr. Khan mentioned, my goal is to kind of give an overview of some of the topics that further speakers will discuss in more detail. These are my disclosures. Pictures are okay. So what I'll call the dual problem of population health in the U.S., and this echoes back to some of the slides that Dr. Khan just showed, is defined by one, poor population health, and here you can see that mortality rates in the U.S. are very high and worsening compared with similar countries, and two, high spending on personal health care, and again you can see here that the U.S. has very high spending per capita relative to other countries. The dual problem is partially interrelated because poor population health can lead to greater healthcare spending. So just as Gotham City has higher police spending than Andy Griffith's Mayberry, North Carolina to try to prevent crime, a sicker population will tend to increase healthcare spending as part of an effort to treat those in poor health. However, I want to argue that the dual problem is mostly not interrelated. That is to say that most of the reason for poor population health doesn't have to do with the healthcare system at all, and most of the reason our healthcare spending is high doesn't have to do with the fact that population health is relatively poor. Instead, poor population health mostly stems from social conditions created by public policy, and high healthcare spending is mostly related to how we finance the production of healthcare services. Starting off with poor population health, there are many aspects of public policy that contribute to this, and Dr. Kandula will cover several of these in more detail later in this session. But basically, our public policy does not create the conditions needed to be healthy for many people in the U.S. A key reflection of this is indicators of material deprivation, such as poverty, where you can see the U.S. is a leader among similar countries, and food insecurity, where the U.S. is also a leader among similar countries. Both poverty and food insecurity are known to have very negative impacts on health, and these statistics are reflections of the broader fact that a lot of people in the U.S. just don't have the basics that everyone needs to be healthy. When it comes to high spending, we need to remember that spending is the product of the amount of healthcare services used times the price of each service. In the U.S., the amount of services used is not really that different from other countries, but prices are a lot higher. This is why you can publish papers in major academic journals with titles like, "It's the Price is Stupid," or a decade and a half later, "It's still the price is stupid." Why are prices high? The main reason is the U.S. private multi-payer approach to healthcare finance. In this approach, private insurance firms are tasked with administering healthcare spending and purchasing healthcare services on behalf of individuals, and market competition in this process is supposed to drive down prices. But it turns out that that doesn't really work because no one purchaser can exert enough downward pressure on prices. In economics terms, the U.S. does not have a monopsony purchaser. Rather than hold down prices, private insurers routinely negotiate very high prices. Just as an example, a report from RAND found that private insurers will often pay 2 to 3 times more than Medicare for the same services. And right now, as many in the room are well aware, there's a particular issue with newer cardioprotective diabetes medicines, which have amazing clinical benefits, but often prohibitive prices. And I'll just mention that Dr. Sokol will talk more specifically about pharmaceutical prices in her talk later in this session. Beyond the lack of monopsony power, another reason both healthcare prices and spending are high in the U.S. is that the private multi-payer approach creates additional administrative work. Now, any healthcare system will need some amount of administrative work, and so there has to be a certain level of spending that's devoted to that. But there's additional administrative work that's generated by the private multi-payer approach as organizations deal with different organizations under different contracts with different rules. And this is essentially extra work that doesn't produce better health but still needs to be paid for. The Congressional Budget Office examined this and found that about 32% of private healthcare dollars go to administration, but with a public payer, it's only about 13%. And this equates to about $500 billion per year on healthcare administration spending that is in excess of what would needed to be spent just to keep the system going overall. Given these problems, then, the natural next question is, well, how do we get better? Fundamentally, I think we need to work in parallel to improve both the healthcare system and the public policy. Now, some people might argue that you want to separate these two things, but I think in practice that's actually hard to do because, one, the healthcare system is itself a result of public policy, and two, in healthcare, we care for people in the context that public policy creates. And so although there are a number of policies that we might change to improve health, both ones that affect healthcare directly and ones that affect the social conditions more generally, I think we should think of these as part of a unified project to improve population health. What are some specific places we might focus on to improve population health? In the context of public policy, one thing we can do a lot better on is income support programs. So this is a distribution of personal earnings in the U.S. that comes from census data. And if you look at this distribution, you'll see that only about half of people in any given year have any personal earnings. And without income support programs, people in this situation are at high risk for poor health because they're not able to buy the goods and services they need to stay healthy, or they may not be able to. So that brings up the question, well, why is it that 50% of people in the U.S. don't have personal earnings? This, I think, seems like kind of a shocking statistic when you first hear it. Well, despite what you might hear on the news, the reason is not because people are lazy or because nobody wants to work anymore. Half of people don't have personal earnings in the U.S. for reasons that are sort of normal parts of the human life course. For example, about 40% of people in the U.S. are adults over age 65 and children under age 18. And in general, we don't expect people in these age ranges to earn their living through paid labor. And about 10% of the population is what we might call working age, that is between age 18 and 65, but not working at the moment because they have an illness or disability that prevents them from working, or are a full-time student, are providing caregiving, such as raising children, or are actively looking for work and are just temporarily between jobs. So people in these categories can't really be expected to engage in paid labor because they either physically can't, or their time is already being spent in other ways, like looking for work or caring for other people. Now, this is a known problem that societies face. In fact, the distribution of people who can engage in paid labor at any given time is very similar in the U.S. compared with other countries. This is basically just a fact of modern economies that public policy has to grapple with. Fortunately, the way to address this problem has been known for over 100 years. It's called social insurance, and it's a way to get income to people who have a covered reason for not engaging in paid labor. But where the U.S. is different from other countries is in the weakness of our social insurance programs. The U.S. does currently have programs for the 6 key reasons people are unable to engage in paid labor. For example, there's Social Security, old age and survivors insurance, the Social Security checks, child tax credit for children, disability income programs, unemployment insurance. But these programs in the U.S. all have major weaknesses with regard to who they cover, their benefit levels, the process for enrolling in benefits, et cetera. And so strengthening each of these programs would be a major step towards better population health by getting income to the people who otherwise don't have it. Now turning our attention to within the healthcare system, an important thing we can do to advance the healthcare system, is advance the healthcare system's ability to respond to patient context. This means making disease management programs that address barriers to health, like food insecurity, covered benefits within routine care. Many people may have heard Dr. Monica Peak speak eloquently about this last night. Fortunately, we now have good evidence-based models of how to do this at scale. Just in the past few months, there have been 2 large studies examining the impact of this approach within state Medicaid programs, one from Massachusetts and one from North Carolina Medicaid, which I was involved in evaluating. Both programs show important health gains from addressing social context as part of healthcare. Another thing we can do is to start thinking of healthcare as a service that everyone needs as a normal part of their life. The need for healthcare is no longer a rare event to be insured against. Instead, it makes more sense to think of healthcare along the lines of your local elementary school, something that everyone predictably needs at times in their life. And so we should arrange and finance healthcare in the U.S. with this in mind. Doing so will facilitate changes in our healthcare system that Dr. Chin will speak about, in particular changes that refocus healthcare on providing continuous coordinated care across a life course. And finally, I just want to mention that the problems in our healthcare system are not resource constraint issues. There's plenty of money to do what needs to be done, and in fact, the CBO estimates that we can pay for healthcare for everyone in the U.S. for less than we currently spend if we better arranged how we do so. So to sum up, poor population health and high healthcare spending are only somewhat interrelated. Poor population health mostly stems from public policy choices, and high healthcare spending mostly stems from the private multi-payer approach. What's keeping the U.S. from better population health is us, but we can change that. We can use public policy to create conditions in which people can be healthy, and we can organize healthcare as a service for people to use across their life course. Thanks very much, and I'm excited to hear the other talks in the session.
Hi, everyone. I'm really pleased to introduce Dr. Mariana Socal, who is a Associate Professor of Health Policy and Management with a joint appointment in our business school at the Johns Hopkins Bloomberg School of Public Health. And we're really excited to have you come up here today and join this session. She was also my student, apparently, in the Advanced Epidemiologic Methods course many years ago.
It's going to be a test of your teaching.
No pressure on me to do a good job, right? All right. Well, thank you so much, everybody, for coming to the session, and special thanks to Steve for having me, and to my fellow panelists today for this incredible discussion. So I will be focusing on cost of medications. And I would like to acknowledge both my funding sources and my co-authors in this work that we will be discussing today. I mean, it's very clear that we have an urgent need for policy reforms when it comes to medication affordability. We already discussed how much it impacts our population, but I think it is important to mention that we all know drugs don't work if people can't afford them. And you can have both immediate repercussions, an emergency room visit, for example, or long-term complications from the lack of access and affordability. Another thing I should say is that the sheer numbers of prescriptions that are filled every year, they're so high. In 2023, there were over 400 million prescriptions for diabetes dispensed in the United States. So really, at this level, each dollar counts. Each dollar makes a difference. And there is unfortunately, there's a vicious cycle here, because the more we have higher costs that we have for payers, the more payers have to implement strategies to lower the spending. And that results in higher costs for patients, more costs shifting towards patients, and more restrictions to access. So prior authorization and other requirements to try to lower spending. So it becomes this cycle where high spending reduces access down the line. And I want to argue that it is the financial burden on patients and on the system that really underscores the discussion for us today. Of course, there's multiple factors that affect affordability, but I will focus on 3 of them. And first and foremost, like Seth just mentioned, we really need to address the issue of prices. For a branded product that does not have competition, does anybody know how much more we pay as compared to other developed countries? We pay on average 3 to 4 times higher prices. So this is 300%, 400%, right? But the moment that we have competition in markets where we have generics, how much do we pay as compared to other countries? Sure, this wasn't in the bingo card for today. We pay a 15% discount as compared to our peers around the world in well-functioning generics markets. So we really need the market competition in this country to bring down prices. And this is a graph, not to ruin your morning, but to show this is insulin glargine price trajectories, and we could see, increasing prices until biosimilars are available, and that's what really changes price trajectories for these drugs. The problem here is we have a very generous patent system in which some drug manufacturers have been very successful in preventing competition from entering the market, and that's what sustains prices up. And we'll talk more about that in a second. Second problem that I want to bring to all of you is this issue of non-transparent prices. I mean, I'm sure everybody has heard at least once how difficult it is to know how much a drug really costs in the United States. At least in my area, we hear it's impossible to know how much a drug really costs. But why is that? Well, it's because we have a confidential system to lower drug prices. And I'm trying to show you here in this slide how big this difference can be, what the magnitude of these confidential deals can be. So on the left-hand side here, we have the price in the supply chain. Is the price that the drug manufacturers set for their drugs. And pharmacies, distributors, everybody has to pay that price. Once that price is paid in the supply chain, later, usually at the end of a quarter or a semester, the manufacturer will adjudicate those revenues, and they will send back money back to insurers in the form of a rebate check. And that is confidential. So follow me here for one moment. The moment that the patient gets to the pharmacy and they hear how much they have to pay up front to get their drug, in that moment, these confidential prices are not available. They haven't been adjudicated yet. So from a patient perspective, all that the patient sees in that moment at the pharmacy counter is the price determined by the drug manufacturer. So when a patient has to pay a coinsurance, for example, a percentage of the list price, 20% coinsurance is very frequent for these high-cost drugs in our market. When a person has a deductible, or when their drug was excluded from the formulary altogether and this person needs to pay cash, they are paying based on this higher list price, nothing compared to the lower prices that the insurer was paying. I show you here a calculation of a scenario where the person is required to pay a 20% coinsurance, but when everything gets accounted for, that patient pay, that amount that the patient paid, it ended up representing more than 50% of the drug cost. Why? Because that was money passed back to the insurer, and the insurer's liability gets small compared to what the patient paid. This particular problem is the issue why drugs are often unaffordable, even to patients who have full insurance. So we often tend to think that drug affordability is for under or uninsured, but unfortunately, this affects everyone. Finally, most health insurers in our country, both public and private, they tend to hire a pharmacy benefit manager to both implement these negotiations that I just talked about and develop the drug formulary, the drugs that will be covered under that plan. And unfortunately, the way that these entities are compensated today, they're compensated not as an upfront fee for their services. Like one would imagine, all services that we typically get in our market, you know how much they cost. In this case, the pharmacy benefit managers, they get paid by keeping a portion of the prices and rebates that they negotiate. Well, logically, this gives us an incentive for PBMs to choose a more expensive product, even when a cheaper generic is available. The government has estimated that in Medicare Part D alone, this accounts for an extra $3 billion a year, just for branded drugs that have a generic and the branded was chosen instead. So how do we fix these issues? Well, I provide here 3 different solutions. I can tell you that there is strong bipartisan support for most of them, and they do have a very strong potential to actually improve affordability for all of us. First, because we rely so much on competition to bring down prices, we should focus on increasing competition, reforming our patent system that allows these monopolies to basically be maintained for decades and decades on end. Facilitating by patent legislation, this has been repeatedly reintroduced. We've seen even this year the reintroduction of patent legislation. Facilitating substitutability of drugs once they are available. The second option is expanding the Medicare drug price negotiation program. It was recently started. The current administration is still taking on this program, and it's a program that very smartly addresses drugs that have been in our market for a long period of time and do not have competitors available. What this program does is that the final negotiated price is transparent. In fact, these prices were announced last year, even though they're going to be coming into effect in 2023. Because they are transparent, they will immediately be available for a patient that needs to pay based on those prices. Now we finally know how much is the final price. The ways to improve this program is to cover more drugs. In the first round of negotiations, for example, only 10 high-spending drugs were selected. So expanding for more and more drugs is important. Adding more teeth into the negotiation, for example, adding the therapeutic benefit for the drug, it would be important. How does that drug compare to the other ones in the market? That's something that we don't yet do. And even being very ambitious, bringing in prices that other countries pay for these same drugs. All of these things could lower our price. States can also extend the Medicare negotiated price to state payers. And that would allow even commercial insurers to benefit. And finally, reforming the way that these PBMs, these pharmacy benefit managers, are compensated. When we talk to insurers, we'll say, we can't really negotiate. PBMs are so strong and powerful, they basically tell us what the characteristics of our agreement will be. Often insurers cannot even audit what's going on in PBM transactions. So we do need legislation to fix this problem, and primarily making the PBM fiduciary of their clients is important, and disconnecting compensation from these prices that would really resolve some of the incentives. So it's not one single magic bullet. I wish I had it for 8 o'clock in the morning on a Saturday. I really do. But I can tell you we should all stand behind these options, because they could really benefit everybody with diabetes and all of us as well. Thank you so much.
All right, we're very pleased to introduce Dr. Marshall Chen from the University of Chicago, who's going to speak on value-based payment and alternative payment models.
Thanks very much, Liz. So today, this paper became live on the Diabetes Care website, entitled How to Fix a Broken Healthcare System, Pathways to Maximize Health and Well-Being for All. And my talk and the next speaker, Nami Kandulas, are two of the sections from this broader paper. And so what I'll do in my 10 minutes is quickly go over the conceptual model for the paper so you see the context for our particular sections. I'll then switch into measuring the value of healthcare, talk about fundamental payment levers to improve care and outcomes, make it concrete with 3 specific examples, and then by talking a little bit about how payment policy might align with President Trump's Make America Healthy Again initiative. So it's a simplified version of our conceptual model. And so you see at the top, we have like 3 foundational elements that are necessary to think about in thinking about health policy. One, led by our colleague Monica Peet, discusses ethics and culture, and in particular, the degree to which our country believes and supports the ultimate goal at the bottom of this diagram of maximizing the health and well-being of all persons and communities over the long term. A second is political economy. This session was led by Joe Bruce and Colleen Grogan. And these are the political and economic structures that shape our nation, including the healthcare system. And the third, which was led by David Kim, is how we define and capture the value of healthcare. I'll talk more about that. Within this overall context, we spent a fair amount of time talking about health insurance policy, and my main topic today, payment policy, in particular value-based payment and alternative payment models. It's important to note that it's not payment reform for payment reform's sake. The payment should support and incentivize effective population healthcare models. And if you look at the ADA Standards of Care 2025, in our January supplement, there is then a section actually on what is the evidence then for what works for population health. So it's building upon that. Again, ultimately this goal being maximizing the health and well-being of all. So the fundamental problem with the U.S. healthcare system is that it does not value or prioritize the long-term health and well-being of all persons and communities, and does not realize the full social return on healthcare investments. The system still largely rewards and incentivizes the provision of a high volume of services to a more profitable payer mix of privately insured patients, rather than implementation of effective diabetes population healthcare models. In other words, the system prioritizes short-term financial gain over medium and long-term population health. So what's the problem regarding measuring the value of healthcare? So the term value implies both a benefit component in the numerator and then a cost component in the denominator. And traditional clinical performance metrics that are used in these value-based payment programs are what I would call at best a modest attempt to differentially value care and map to payment. So, for example, Medicare and Medicaid, their performance metrics and clinical guidelines often do not reflect the latest cost effectiveness evidence, and they're dominated by disease-specific measures that do not capture overall health and well-being. And policymakers in practice basically focus upon the denominator, cost savings, and largely ignore the numerator, benefit. So they don't think about cost effectiveness, and especially for our economically marginalized groups who have limited political power, such as Medicaid patients, it's all about cost savings. You have very little talk about value. So our recommendations, so measure patient and community health and well-being. So complement disease-specific measures such as A1C with measures of overall health, well-being, function. So for example, the question in general, would you say your health is excellent, very good, fair, poor? Include population health accountability metrics. So Institute of Medicine, they came up several years ago with a number of recommended metrics such as life expectancy at birth, teenage pregnancy rate, high school graduation rate, addiction death rate. So you see, it takes you into a different sort of way of thinking about the world, an overall population health perspective, dovetails with points that Seth made in his talk. Emphasize health for all and improving care and outcomes for those patients and communities not doing well, meaning, for example, examine stratified performance measures by factors such as race, ethnicity, income. Shift from the current emphasis upon cost savings to prioritizing value, i.e. the benefit and the cost. Social return investment, we don't really look at that. So it's not only the health benefits, but also the economic benefits like productivity, if you have a healthy workforce. And then also looking at cost effectiveness evidence. And there are new forms of cost effectiveness analysis that take into account equity and distributional concerns, as well as overall budget impact. So this is a list of these fundamental payment levers, and so I'll go through them and then go through 3 examples that will make it more concrete. So first, you can use payment to specifically reward value, reward improving health equity. Healthcare organizations, they tend to like upfront flexible funding that gives them the flexibility to use the money where they see fit to improve care. So what does that mean? Like things like capitation, global payments, a per member per month payment, bundle payment are all forms of this kind of potentially upfront flexible funding. Risk adjust payment for the medical and social risks of beneficiaries and patients. This is a problem of the cherry picking. So if you don't provide higher care dollars for patients with higher social risk, providers, healthcare systems will want to avoid caring for them. Sort of related to that is you can improve health equity by uniform rates across payers, the same rates regardless if it's a Medicaid patient or Medicare patient, privately insured. I'll give you an example of that. Similarly, I'll give you an example of this next one, incentivizing population health with total cost of care models. If you're responsible for the total cost of care, all of a sudden you have an incentive basically to do prevention and keep people out of the hospital. Prevent profiteering and the bleeding of funds from caring of patients and communities. So health insurance plans have these medical loss ratios where they're required to spend 80 to 90% of their premiums on actual health care as opposed to something like marketing or profit. We talk a little bit on our paper about the financialization of health care and the movement of private equity in the marketplace. You could have provisions that prevent asset stripping. People are probably familiar with the Hahnemann case, for example, in Philadelphia. Reform physician pay schedules using unbiased, rigorous data science analysis to create fair fees for cognitive specialties such as primary care, endocrinology, compared to procedure-oriented specialties. So example number 1, Blue Cross Blue Shield Massachusetts Pay for Equity Program. So they have something called the Alternative Quality Contract Program, which is a precursor to ACOs. The CMS definition of ACOs are here, groups of doctors, hospitals, or other healthcare providers who come together voluntarily to give coordinated high-quality care. When an ACO succeeds in both delivering high-quality care and spending healthcare dollars more wisely, will share in the savings it achieves from the Medicare program. So this Blue Cross program, they have a global per member per month payment to providers, and you get bonuses. So one bonus is this: the overall quality of care across the whole population improves. So rewarding overall improvement in quality. There's also specific equity incentive measures where you get additional dollars if you reduce the disparities by race ethnicity. They also have a statewide learning collaborative to help teach these health organizations how to succeed under this particular system. Second example is Centers for Medicare and Medicaid Innovation, the so-called REACH model. So we talked about ACOs, you share in the savings if your costs are below a specific benchmark. The problem is that it's more expensive to care for patients with greater social risk, as I already mentioned. So there's a perverse incentive to drop high-risk patients from the ACO. What this program does is it has a health equity benchmark adjustment. So they adjust for individual level and neighborhood markers of socioeconomic disadvantage. They divide the population into deciles by disadvantage. If you're in the highest decile disadvantage, you get $30 per member per month more. And if you're caring for patients in the bottom 5 deciles, you subtract $6 per member per month for those. So it's the same dollar cost, but it's redistributed. Maryland is a very interesting state. So they have a total cost of care all-payer system. So the federal government holds the state of Maryland responsible for the total cost of care of the Medicare beneficiaries. Each hospital gets a global budget, so hospitals have an incentive to keep populations healthy. Early results, promising. Decreased ED visits and hospitalizations, decreases in preventable hospitalizations, $700 million in savings in the Medicare program. With the all-payer system I mentioned, where all insurers pay the same rate, you don't have an incentive to cherry-pick the highly reimbursed privately insured patients. I'll end then with a little bit upon, again, MAHA. And so May 13th, the information, these 3 pillars: prevention, empowering people, competition. And their director, they talked about some examples, so including waivers to incentivize preventive care, evaluate preventive outcomes such as days at home for frail people, prioritize high-value care, incentivize reductions of unnecessary utilization, require that all alternative payment models involve downside risks so you can lose money, so sort of like the total cost of care models, that a growing proportion of Medicare and Medicaid beneficiaries are in global downside risk arrangements. So it's basically what I said there. And again, I'll just sort of leave you then with recommending again that you do click on this in terms of our article, big article, 19 pages with references, 170 references, 6 tables of recommendations. It became sort of a love project here with NAMI and other colleagues, and so we think you'll find it helpful. Thanks very much.
I'm very pleased to introduce Dr. Nami Kandula, who is a professor of general internal medicine and also epidemiology at Northwestern University. And she's going to be discussing social drivers of health. So thank you so much, Nami, for joining us.
Thank you so much to Stephen and Liz for the invitation to participate in this very important conversation this morning. These are my disclosures, and it's okay to take pictures. So let's start at the end of my talk with the main points I'd like you to take home today. But that doesn't mean you can fall asleep. I hope you would still pay attention. The social drivers of health are the non-medical factors that influence people's health and well-being, the conditions in which people live, work, and age. This includes things like whether you have safe housing, access to healthy food, reliable transportation, and a living wage. These social drivers influence U.S. population health, including diabetes prevalence, prevention, treatment, and outcomes. Medical care is insufficient for ensuring better population health in our country. Improving population health in the U.S. requires all of us: health systems, health professionals, patients, community and social service organizations, and policymakers, to recognize and act on the social drivers of health as fundamental to our mission and to the health of all Americans. Social drivers of health are shaped by the distribution of money, power, and resources at the global, national, and local level. This figure from the World Health Organization shows how social, economic, public policies, governance, and culture and societal values give rise to the social drivers of health, the conditions in which individuals are born and live. The socioeconomic and political context creates stratification of people according to class, race, gender, and shape how education, income, and labor are distributed across our society. A person's socioeconomic position, in turn, shapes specific determinants of health status via their material circumstances, such as the neighborhood they live in, their working conditions, the availability of food, as well as behavior and biology and psychosocial factors. This framework departs from many previous models by conceptualizing the health system itself as a social driver. The role of the health system as a social driver of health becomes particularly relevant through the issue of access to health care and by health systems working with other sectors to improve health. The health system does play an important role in mediating the differential consequences of illness in people's lives. As Dr. Berkowitz mentioned, poor population health is a consequence of these social drivers and material inequities across a society. Compared to peer nations, the U.S. spends far more on healthcare and far less on social supports. Despite generally lower per capita incomes, many of these Western European democracies spend a greater proportion of total health and social services expenditures on actual social services. And these other countries do have better health outcomes than the US, as we've seen previously. For example, the per capita income in Germany is roughly the same as in Mississippi, yet Germans live nearly a decade longer. It's the underinvestment in social drivers that's at the heart of poor population health in the United States. So here are three key ways, particularly relevant to diabetes, in which inequities in socioeconomic and material conditions lead to worse health and higher healthcare spending that we see in the US. First, food insecurity leads to increased consumption of inexpensive and unhealthy foods. Second, there are psychological pathways whereby the stress of living in poverty or in an unsafe neighborhood worsens mental health, which in turn affects biology and behavior. Third, there are financial trade-offs between basic needs and products that people need to make for their health. For example, a patient may skip medications to pay for their food or their rent. So these pathways reinforce one another across the entire life course, leading to poorer health outcomes and costlier health care. And as we've heard, the healthcare system cannot fix everything, but healthcare systems are central actors that can implement social care solutions. Health systems can screen for health-related social needs, build partnerships with social service and community organizations to address these needs, and advocate for policies that align social needs and healthcare. In the paper that accompanies the symposium, we provide real-world examples and detailed recommendations to support healthcare system action on these social drivers of health. I'll provide a brief overview of our main recommendations. First, we need movement towards healthcare systems that use value-based models that explicitly finance these social drivers, like housing, food, transportation, alongside medical care. Medicaid 1115 demonstration waivers offer states an avenue to test new approaches in Medicaid that differ from what's required by federal statute. And there's many states that are testing ways to address social drivers using these Medicaid waivers to pay for social supports. One example is North Carolina's Healthy Opportunities Pilots, which pays for screening and then funds housing, support, nutrition, and transportation through community partners. Dr. Berkowitz's evaluation of this pilot showed initial uptakes in spending, followed by net savings and improved health outcomes among participants. These data support the idea that Medicaid 1115 waivers for health-related social needs should be expanded. However, in March 2025, the Centers for Medicare and Medicaid Services rescinded guidance on the coverage of health-related social needs, stating that they will consider states' applications to cover these services and supports on a case-by-case basis. As key actors, health systems must avoid medicalizing the social drivers of health. This means recognizing that these social drivers affect all kinds of Americans, and also recognizing that some people are more affected because of their social identity. For example, where they live in a rural area, their race, ethnicity, their immigration status. So we can't use a one-size-fits-all approach when designing healthcare programs that address these social drivers. To address these complexities and the need for tailored approaches, health systems should intentionally build partnerships with social service organizations and community partners and approach this work together collaboratively. A multi-sector approach is necessary to holistically address social drivers and engage the communities that are most marginalized. So our recommendation, fourth recommendation, is to pool health and social sector dollars rather than having health systems try to go at it alone. We can do this through braided and blended funding models, which can lead to greater success when we're trying to address these complex social drivers. So braiding involves coordinating funding from multiple sources, maintaining separate accountability for each funding stream while aligning them towards a common goal. Blending combines funds from various sources into one funding stream, removing individual funding identities and allowing for more flexible use of these resources. One example of a braided funding model is Louisiana's Permanent Supportive Housing Program. This is a joint initiative of the State Medicaid Agency and Housing Authority that combines rental assistance with optional health-related services on site for people with substantial physical or behavioral disabilities. By braiding together natural disaster recovery grants, federal rental subsidies, low-income housing tax credits, and Medicaid, the program ensures stable housing and on-site health and social care. This evaluation of this program shows that it has led to fewer hospitalizations and institutional stays. And what's really important is it leads to stronger community integration for people with disabilities. Finally, this is like my pie-in-the-sky dream, would be a health in all policies approach, which is a collaborative approach to improving health outcomes by incorporating health into decision-making across all sectors. This approach uses health impact assessments to make sure that every major policy decision, whether it's about housing, transportation, labor, zoning, or education, will actually help improve the health and well-being of those who are impacted by these policy decisions. While a national health in all policy strategies is a long-term goal, there are really great examples at the local level in the United States, including Richmond, California, Nashville, Tennessee, and Lexington, Kentucky, where a health in all policies approach is making well-being of the community a societal value, and it's being used to improve population health. So, many of us in this room, I think, feel uncertain about the future of the U.S. healthcare system. And some may even be pessimistic because current policy proposals could further erode social spending and reshape healthcare to be less responsive to social needs. But it's in moments like this where it's essential to stay anchored to our North Star. We should all be asking the question, how do we design a healthcare system that truly maximizes the health and well-being of every person and community? So stay focused. Each of us can be a champion at the local, state, and national level. We can make progress if we continue to raise awareness of how social drivers impact health, like what I'm doing today. We can build cross-sector partnerships and organize around specific actions that are necessary to achieve a nation where every person has a fair and just opportunity for health. Thank you.
Thanks very much, Nami. And now it gives me great pleasure to introduce to all of you our fifth speaker, who happens to be a person with type 1 diabetes, a pediatrician, and now a congressperson who represents the great state of Washington, which is where I come from. Congresswoman Kim Schreier is going to talk to us a little bit about her views of what we need to do to deal with funding of research and disease surveillance. And she has, in the short time that she's been in Congress...
But we have people suffering from the cost of prescription drugs now.
But we'll get there. In the short time that she's been in Congress, she's advocated very strongly for healthcare services and ensuring an adequate workforce across healthcare, but particularly in pediatrics. And she's more recently been speaking out very sternly about all the cuts that have been proposed to HHS, FDA, and CDC. Kim, it's a great pleasure to have you here, and we'll start with your video, and then you can come up and join us.
But we have people suffering from the cost of prescription drugs now, and intentionally holding up this bill hurts them. We absolutely must remain the leader in the world in innovation. But the thing is, we can reduce drug prices and still have money for research. I am the first pediatrician ever elected to Congress and currently the only female doctor here. I'm also... All right, it's my time. I am also a patient with type 1 diabetes. My life depends on insulin. So the high cost of prescription drugs affects me and people like me every day. When we talk about the cost of insulin, I have felt that personally. I've seen the price of my insulin go from $40 a bottle to $300. That is the price for a bottle that holds 10 milliliters, 2 teaspoons. Before being elected to Congress, I worked for nearly 20 years as a pediatrician in the suburbs of Seattle, just 3 hours from the Canadian border. Mostly, I sent electronic prescriptions, but when patients asked for a paper one, I knew it was because they were going to Canada to fill it. Right now, we pay 3 to 4 times what our colleagues overseas pay, and that is why we must use the negotiating power of Medicare to bring prices down.
I also like that you talked about the other incentives, and I think Operation Warp Speed is really a perfect example of how government incentivized research development, manufacturing of vaccines that have saved millions of lives. I think that's been forgotten in this country, but that was incredible. I also will mention that ACIP also vetted those vaccines and is directly tied to saving millions of lives. Ms. O'Connell, it is great to see you again. I was wondering if you could first just discuss how federal research over decades led to development of the COVID vaccines in less than a year, record time.
Well, that's exactly right. And one of the things I think people forget is that when the Trump administration first started Operation Warp Speed, they invested in an entire suite of candidates of various platforms. And each of those platforms came through some early research work that NIH did and some advanced research and development that BARDA did. So the government was critical in helping to see the success of each of those platforms come through. It turned out that the mRNA platform was the one that moved as quickly. You know, you mentioned the one that was done within 11 months. We were able to, the Trump administration at that time was able to push that research through and develop that vaccine. And it did provide significant protection for millions of Americans.
Thank you. And just to double click on that, NIH research over 10 years led to that, and China is. Thank you, Mr. Chairman. First of all, I just want to associate myself with so many of the remarks from my esteemed colleagues about the NIH and what it means to arbitrarily say you can only spend a certain amount on indirect costs. And I thought the first thing I should do is just remind people that the United States is the gold standard for research for a reason. We, in a bipartisan way, decided to fund the National Institutes of Health in order to supply the resources to our most brilliant scientists at universities across the country to do the research that would allow the entire world to take leaps forward. And I think we are all so proud of this record of accomplishment in our country. I want to point out a couple other things. Just the word indirect gets thrown out there as though it's, a slush fund or something like that. The reality is direct funding is what you think of. It's the laboratories, it's the salaries for the scientists, it's the bench, the place where they work. Indirect means that it may not be used for a single research project, but it could be used for the entire university. It could be the building, the equipment, the lab, the infusion center, the MRI machine. It could be the grant writers. It's keeping the lights on. These are not insignificant needs, and many, as we've heard, of our universities get about 50% indirect costs. And I also just want to clarify some math on that. 50% does not mean that half the money is spent on indirect. It means that for every dollar spent on research, 50 cents is added for some of these equipment and upkeep and the like. So for those of you who don't watch C-SPAN, now you know what happens in the House. But I wanted you to have a real example of what happens there, because I think for most people there's a real disconnect, and I want you to know that I'm fighting for you. Thank you, Dr. Khan, for your introduction. Thank you for having me today. Thank you for all being here. As you heard, I represent sort of the middle of the state of Washington, and I'm Kim Schreier. I'm the first pediatrician elected to Congress, and I have also lived with diabetes for now 40 years, pretty much exactly. On April Fool's Day when I was 16, my doctor diagnosed me with type 1 diabetes, and of course I asked him if he was joking. But I knew that this was no joke and that it was real, and it changed the trajectory of my life. First, because my incredible pediatric endocrinologist, Dr. Fran Kaufman, who is at this conference, inspired me to become a physician, a pediatrician, so that I could take care of children just like she did. And then later, as a patient and a physician, I saw firsthand the challenges and the opportunities that face our whole nation's medical system, and you've just heard about a lot of them. And what I saw really underscored the point that sometimes what you need is system-wide change, as you heard, to really make a difference. So we saw this system-wide change with the passage of the Affordable Care Act, life-changing legislation that finally made it possible for people with pre-existing conditions like T1D to purchase insurance on their own. But almost immediately, that law came under attack. Defending the 26 million Americans who could finally get health insurance under the ACA was one of the reasons, along with significant urging from a lifelong friend, that I decided to run for Congress in 2017. And after that first successful campaign, I became part of the wave of women who changed the face of the U.S. House of Representatives when we were sworn into office in 2019. And healthcare has really remained a top priority for me during my time in Congress. I currently serve on the Energy and Commerce Committee. Doesn't sound like it, but that has jurisdiction over most healthcare policy. So every day I work with my colleagues in both parties to expand access to affordable care for all Americans and to ensure that America continues to lead the world in cutting-edge research and epidemiology, particularly for today when it comes to diabetes. That's why one of my first missions, as you heard, was to reduce the cost of life-saving medications. And we did it. Through the passage of the Inflation Reduction Act, seniors on Medicare now pay just $35 a month for insulin. And this effort, according to my endocrinologist, has trickled down. Like the drug companies saw the writing on the wall and lowered prices for Americans of all ages. That shows it can be done. As a pediatrician, I have taken care of kiddos with new onset T1D, so I understand both the dangers of DKA and how stressful it is for patients and their parents to have that new diagnosis happen in a crisis in the hospital. And that's why I introduced a bill to support screening for diabetes. It's called the Screen for Diabetes Act, to catch it early, long before those new onset patients end up in the emergency room. And early detection could even spare them the entire hospital experience. And as someone with type 1 diabetes, I also remember how important that initial diabetes education was when I was diagnosed 40 years ago. I remember the orange where they showed me how to give a shot. I remembered the food exchanges. Those lessons have stuck with me. And that's why it's been a real priority of mine to ensure that people with type 2 diabetes on Medicare have access to that education, both in person and online, and without a limitation of timeline. This bill is called the Expanding Access to Diabetes Self-Management Act. And while we got it through committee last time, it never made it to the House floor, but I'm going to make sure it does this year. While in the minority. I also co-sponsored the Prevent Diabetes Act that will ensure that telemedicine is there as a permanent option for Medicare diabetes prevention programs. Most importantly, and I'm sure there are researchers in the room, I know that preventing and curing diabetes are our North Stars. But the two other major goals, of course, are managing it well and preventing and treating complications. Which brings us to the Diabetes Caucus, one of the largest bipartisan caucuses, otherwise known as groups, in Congress. And we work together to do everything we can to advocate for research and prevention and management of diabetes so that people can live the healthiest lives possible. And it makes me proud, and it should be reassuring to you at such a divisive time when it really feels like government is broken, that this caucus is working together for common goals. And one example of that work right now is that we want to reverse these harmful NIH funding cuts that have already stopped some ongoing studies in their tracks, and if not reversed, will set back diabetes research by years, will discourage the next generation of student researchers, will defund our universities and other research institutions, and it will rob hope from so many people with all types of diabetes. So I want to emphasize that if this NIH funding isn't there, it removes the funding that not only supports the research itself, but that also supports the training of the next generation of scientists. And we need those brilliant, young, enthusiastic minds and should be supporting them, not ending their careers before they can even begin. We will see, in fact, we are already starting to see a brain drain of researchers and medical experts in this country who are now pursuing foreign universities that will enthusiastically welcome them and support biomedical research. So these decisions at the NIH, I should broaden that, these decisions by RFK Jr. at HHS are not just wrong-headed, they are just plain stupid. They will kneecap U.S. leadership in the world when it comes to cutting-edge research, and frankly, they will just hand the wheel to China. In March, Democrats and Republicans in the caucus, the Diabetes Caucus, came together to demand answers from HHS Secretary Kennedy about this reckless decision that would slash funding for diabetes research, including a decades-long study on diabetes prevention, and to demand that that funding resume. We're waiting for a response. This is heartbreaking. And infuriating as a physician and as a patient, because one of the areas where both parties have traditionally always historically aligned is biomedical research. There's never been squabbling. We always ask for maximum funding, regardless of party. We have worked together to see the most robust programs for funding for programs like NIH, NIDDK, that will bolster medical research in annual government funding packages. I have worked with both parties to support the Special Diabetes Program, which primarily supports T1D research and breakthrough therapies, and the Special Diabetes Program for Indians, which funds research specifically focused on Native American Alaska Natives, who are, as you know, at much higher risk of type 2 diabetes and complications. Special Diabetes Program funded research conducted and led by many of you here today is why we have new drugs to delay the onset of type 1 diabetes. It is the reason we have CGMs and pumps and looping and therapies to reverse diabetes associated vision loss, and the groundwork, and we're getting close, I hope, to an artificial pancreas system. I know this research funding is critical to the work that all of you do, and I will continue to work with my Republican colleagues in the House who currently control the House and the agenda to ensure that the Special Diabetes Program receives robust, consistent funding, and encourage them to fight these efforts to take away Congress's power of the purse. Consistency of funding is part of this. We have discussed this, that we need annual real appropriations bills. We need longer term funding. And when that longer term funding is guaranteed, it also needs to be delivered. And these recent stopgap funding measures miss the mark. When funding is only guaranteed for a couple of years, this uncertainty hampers research. It doesn't start and then it doesn't get done. And again, it is irresponsible and it is damaging U.S. leadership. And when the money that has been granted is not dispersed, that is already halting studies in their tracks. The diabetes community, the medical research community more broadly, needs long-term funding and certainty, and these piecemeal extensions just don't meet the moment. I want to build just a tiny bit on this topic of uncertainty, because right now we're at a very uncertain moment. Programs and agencies are being torn apart, and the future of research and studies for diseases like diabetes are on the line. As you heard earlier, efforts to manage the social determinants of health and address them are also being undermined. There have been huge changes suggested to NIH's research budget. The indirect funding that I just talked about could drop from 50 to 70% down to 15%, and that will shut down research and it will shut down universities. Indirect funding is not a slush fund, as you heard. It is critical funding. All of this underscores that we're at a pivotal moment right now. And that's really why I'm here today, because government plays a role in everything else that is happening when it comes to policy. We've made such strides in ensuring affordable and accessible health care for so many Americans, making sure people like so many of us here today of all ages and backgrounds who have diabetes can live healthy and long lives. And in Congress, I want you to know that I will always work with my colleagues in both parties to build on these accomplishments. And I will always stand up to attacks that will hinder our progress and our leadership around the world. It's not just the right thing to do. It's not just the common sense thing to do. It's really personal for so many of us in this room. Thank you.
So I have heard applause like that for a long time at this meeting, and I think it's really great that you're here. It's been a long time since somebody from Capitol Hill has been here for many, many reasons, and I think everybody here appreciates it. And the sad thing is that there are so many people at this meeting who hadn't heard you today, so we'll make sure the message gets through. And so as a reminder, the video of this whole symposium will be available online once the papers appear in print, which will be in the next few months, and so you'll all have an opportunity to hear this again. So we're going to have now a panel discussion with everybody here, with questions from the floor and questions that Liz has as well for the panel and for the panel to interact. And we have about 22 minutes to do so and really want this to be interactive and look forward to your questions. So Liz?
So maybe for the whole panel, given the current environment, where do we start with reforms? Like where can we start right now?
That one might be for me. I think right now, I'm in the minority. I mean, this is a nonpartisan talk, but here's how Congress works. If you're in the minority, whoever's in the majority sets the agenda. Whoever's in the majority decides what we talk about in committee, decides what bills make it to the floor of the House. And so right now, my role is to educate, to raise these issues, to let people know what's happening with NIH, to make sure that the entire country understands that the cuts that are about to happen to Medicaid, which probably is item number one right now, is going to collapse our entire healthcare system. And so we need to get that message across, because it's people in a democracy who can influence politicians, their own representatives, who should answer to them and not to a president, to put pressure and to pass the bills that will help their constituents. So right now it's making a lot of noise, making sure everybody knows what's going on and why.
Yeah, I build upon Dr. Schreier's point that I think what's different for us now compared to like a lot of prior issues is that, as one of my colleagues said, the House is on fire and there's not a lot of time to save it. And so it's not just the healthcare cuts, it's the cuts in all the different social sectors, which, as Seth and Nami said, ultimately lead to the health problems and the health inequities and all. And so in some ways, like, it's not just the incremental things we do in healthcare, it really is the whole system where there's going to be increased demand for services and decreased resources unless we act.
I think one other question I wanted to follow up with Dr. Schreier's point about the Diabetes Caucus. Can you tell us in this room, what should our strategy be? What can we do? How can we engage with the Diabetes Caucus?
So you can engage with the Diabetes Caucus more broadly, but usually what people do when it comes to lobbying their members of Congress in Washington, D.C., is they meet with their individual member. People have meetings with me. They call us on the phone. Our office takes note of every phone call. We respond to every phone call and email. I mean, that's really you all come from different districts, different states. Talk with your member. Put the heat on them to make sure they understand what NIH funding does, what will happen to the university in their district, what will happen to their constituents, the number who are on Medicaid. Pick your angle, depending on who it is, and make the message clear.
Let me just follow up on a couple of things you mentioned, Congressperson Schreier. In Seattle, the University of Washington now is apparently no longer taking NSF grants or DOD grants because their indirects are being fixed at 15%. They say we cannot do this. So already funding is going down. And then you talked about the diabetes prevention program. There's some good news on that through your efforts, and particularly Senator Sheehan from New Hampshire that doesn't even have a clinic in the diabetes prevention program. It looks like the money will be restored next month and that program will start up again if the promises we've been hearing in the last week come through. So thank you for your efforts on that too.
I had one question for Mariana. With all the companies doing direct-to-consumer sales for pharmaceuticals, how does that change things for us in the context of your talk and what do we need to do? How do we think about this?
Thank you so much for that question. Yes, that's increasingly common. And I want to mention, even before I say anything, I want to mention that drug manufacturers, they are not bound by HIPAA laws. Okay, so that's a very important problem. Often, in order to provide either the sale or a benefit like a patient assistance program or a coupon card, manufacturers collect your name, your date of birth, your address, often your tax returns and your social security numbers. So even before we talk affordability or access, we have to also remember, how much we need to protect patient privacy in these situations. That having been said, the experience of patients is still determined by their health insurance benefit design. So it will be a question that we will have to see how it evolves on how health insurers will decide to cover direct from manufacturer sales. We know that when the drug is affordable and the person can pay out of pocket because it's a reasonable cost, that can be present. And we see it, for example, Walmart saying direct to consumer. We see it, Mark Cuban selling direct to consumer, because these are low cost generics. But when we started seeing this for branded products, health insurers will have to step in, and we will have to see if they will consider these entities as a preferred pharmacy in network versus out of network, which for patients increases their cost sharing. So there's a lot still for us to monitor as this environment evolves. But I can tell you for patients, sometimes the trade-off will be you get a lower cost, but then you provide your personal information.
Thank you very much. I'd like to take some questions from the audience. I know we have some, we come to the mic. Please introduce yourself and keep your question short.
Hello, I'm Dr. Stina Wedlock. I'm an internal medicine physician from Indiana. I have two quick comments and a question. First comment, 7 years ago, our practice reorganized into a team-based practice and adopted value-based care model for our reimbursement and also for our physician incentives, and it works beautifully. So for anyone who's thinking about it, go for it. Two, Dr. Schreier, thank you for everything you do. I really hope they get you a new nameplate that says Dr. Schreier, because I think your experience and your expertise needs to be in their face all the time.
It's not. Super weird thing. It's not allowed. I can be Ms. or Mrs. Those are my choices.
My question is, several people spoke about reforming the way healthcare is financed and reforming PBMs. My understanding is approximately 20 to 30% of our workforce is employed in healthcare, including in those areas. And I'm just wondering if anyone has a sense of what the economic impact on that kind of reform would be.
I'm happy to speak to that. So first of all, PBMs have been in our market since the 1960s, and they do bring a lot of value. I think reforming how they get compensated will will have a financial impact on insurers and consumers, not necessarily on PBMs and their workforce. In fact, it would even support further, now that we're seeing efforts, for example, for vertical integration, PBMs being more integrated with insurers and pharmacies. So those models, I think, will also have to change consecutively. But generally speaking, the value that these entities bring into the market will not only remain, but be supported by these initiatives. Because at the end of the day, the clients that are the health insurers primarily would be better able to see the value that these entities bring. Today, health insurers are pretty much in the dark. I work with self-insured employers, and we can think about the biggest companies in the nation, and they don't have information on their own data.
May I add to that? Big bipartisan priority is taking on the perverse incentives that are driving PBMs to jack up prices. So thank you for those comments. I also wanted to point out the vertical integration that is making things worse. And then in terms of the workforce specifically, there is so much workforce right now devoted to dealing with pre-authorizations and other stuff that should not exist. And it is, at least within the doctors, a bipartisan priority to take on these issues with Medicare Advantage, with pre-authorizations, to basically end all the paperwork and just use our medical dollars to provide medical care.
I'd like to take a question from the back microphone.
Hi, everyone. Nita Lighterapong, general internist, University of Chicago. I want to commend this talk for the group of you for talking about these really difficult issues, complex topics, breaking them down, making them simple, and then also not making it death and dire for a Saturday morning. So thank you for that.
My question is, several people spoke about reforming the way healthcare is financed and reforming PBMs. My understanding is approximately 20 to 30% of our workforce is employed in healthcare, including in those areas. And I'm just wondering if anyone has a sense of what the economic impact on that kind of reform would be.
I'm happy to speak to that. So, first of all, PBMs have been in our market since the 1960s, and they do bring a lot of value. I think reforming how they get compensated will will have a financial impact on insurers and consumers, not necessarily on PBMs and their workforce. In fact, it would even support further, now that we're seeing efforts, for example, for vertical integration, PBMs being more integrated with insurers and pharmacies. So those models, I think, will also have to change consecutively. But generally speaking, the value that these entities bring into the market will not only remain, but be supported by these initiatives. Because at the end of the day, the clients that are the health insurers primarily would be better able to see the value that these entities bring. Today, health insurers are pretty much in the dark. I work with self-insured employers, and we can think about the biggest companies in the nation, and they don't have information on their own data.
May I add to that? Big bipartisan priority is taking on the perverse incentives that are driving PBMs to jack up prices. So thank you for those comments. I also wanted to point out the vertical integration that is making things worse. And then in terms of the workforce specifically, there is so much workforce right now devoted to dealing with pre-authorizations and other stuff that should not exist. And it is, at least within the doctors, a bipartisan priority to take on these issues with Medicare Advantage, with pre-authorizations, to basically end all the paperwork and just use our medical dollars to provide medical care.
I'd like to take a question from the back microphone.
Hi, everyone. Nita Lighterapong, general internist, University of Chicago. I want to commend this talk for the group of you for talking about these really difficult issues, complex topics, breaking them down, making them simple, and then also not making it death and dire for a Saturday morning. So thank you for that. My question is this. I like to think about research as a tool to help others, design better systems. And so from your vantage point, are there things that people in the room can do to provide more evidence? I hear the call your local congressperson and give the personal anecdote perhaps, or maybe talk about your research, which is all really important and good. But are there gaps in what we know right now that could help us lobby better, argue better, put pressure on drug companies to make decisions on their own? I think about the insulin movement, where I think it was a combination of researchers producing really powerful evidence for the importance of making insulin cost effective, and then lobbyists and politicians, and then, people trying to get ahead of the problem and just making decisions on their own. Are there other things that you guys need as tools, knowledge that you need that can expedite things in this really trying time?
Is that one for me too? Okay.
It's for anyone.
Yeah. So telling stories is really important. And I don't want anybody in this room to underestimate the power of people in telling stories. We have seen big waves where people let their opinions be known, where we heard stories widely about people who would drop a bottle of insulin on the floor and would try to get as much of that as they could into a syringe because of how expensive it was. And I think that getting those stories out, whatever you do, like if you're good at calling your member of Congress, do that. If you're good on social media, do that without alienating anybody. Just tell the story, make it clear what's happening and how it impacts people. If you're great at writing a letter to the editor, do that. If you happen to be a person on TV, do that. Like whatever it is, just don't stop talking about what matters a lot to you.
Thank you.
Also just add a little bit. So, I am a researcher. I certainly believe in research. I think there certainly is a lot more we can do to learn about how to make policies better and compare different versions of policies, and which, will help us accomplish our goals better and things like that. But fundamentally, I don't think we should make it seem like that there's a real significant knowledge gap in what we need to do here. This is a power problem. It's not a knowledge problem. I think we know a lot about what to do to improve population health. Yes, there is tinkering and more that can be learned. That will always be the case. But fundamentally, I don't think it's a lack of knowledge or a lack of research that is driving a lot of the issues right now.
From the front microphone.
Thank you. Francisco Prieto. I'm a family physician turned diabetologist and been involved with advocacy for the ADA for many years. And I really, more of a comment than a question. First, I wanted to thank the Congresswoman for being part of the Diabetes Caucus and for your leadership, because that means a lot. And I wanted to point out to all of us, really, that our system was broken even before the current administration decided to try throwing a few million people overboard. And we've won some small victories, like $35 insulin for people on Medicare through advocacy. And so I hope all of you will stop by the advocacy booth in the exhibit hall, where there's a video booth, and you can stop for a couple of minutes and tell your story, and we will share that story with your members of Congress, and we'll talk to you about what else you can do. Thank you.
And we read those. I read stories out loud from my constituents in committee hearings. Great time to do it. So do call with your stories.
From our back microphone, please.
Ruth Denver, and I have another member and close friend in Diana DeGette on the caucus. My question is sort of a practical, strategic question for advocacy. FASB has a beautiful map of every state, red and blue, of how much federal funding goes to that state, and for medical research and other supportive programs. And I'm wondering how to articulate that message nationwide so that we can show the economic insanity of cutting biomedical research and other innovative research programs, climate, et cetera. And this is for Dr. Schreier to start and anybody else to take.
First of all, Diana DeGette's one of my besties, so I'm so glad that you know her, and she is co-chair of the Diabetes Caucus. People know these things, and there's a lot of discussion about donor states and taking states, and I think everybody looks at this data differently. So what we try to do is call out, there may not be as many research dollars that go to Louisiana, but Steve Scalise's district has Tulane University. And I think that pulling it out in that way, you really got to put the heat on people individually. You got to look at Texas. Which representative has Texas A&M or whatever. I don't know all the universities in Texas, but we have to put pressure specifically on representatives who have big research institutions in their. Again, the people who control this are the people in red districts and red states, and so that's who needs to hear about their research institutions, and they are.
Peter Rossing from Copenhagen, Denmark. So in many ways, Denmark was mentioned during some of the talks, and like countries in Scandinavia. And I just want to say, we are of course very terrified by the reductions in research and innovation, because that's what very important things coming from the US to the rest of the world, as you said. And I think in that sense, I really hope that you are successful in your efforts. And you can say in a part, I'm also part of the problem, coming from a country with a pharmaceutical manufacturer producing some of these drugs. But I'm also perhaps part of your solution, although we certainly don't have a perfect system in no ways, but having a single payer system with value-based healthcare that covers everybody with social security and healthcare, where Ozempic costs $4 a day before reimbursement. So in that sense, I think this is a problem that needs to be fixed on a very high level, because it's about how we care for each other in the society. But having said so, I also want to say that we also need to think about what we can do ourselves in our everyday practice. In this country, we just heard yesterday, 30% are screened for kidney disease annually, and you're rewarding nephrologists for doing dialysis. Why not reward people for screening for diabetes complications and then prevent the need for dialysis? And there, I think everybody here and your colleagues just follow the guidelines and try to implement what we are trying to do to the extent possible is a little bit what we can do ourselves. So I'd like to hear from you if you have suggestions to what can be done by each of us today while we're waiting for the bigger solutions, which are of course needed. And then I just want to end by saying that I hope you fix the problems here, but otherwise Europe is open for free research.
I think you guys are already recruiting. Thank you for the research you're doing. Thank you for providing life-saving drugs. It's very hard to compare our country. I mean, we all talked about social determinants of health. To compare our country, I mean, you don't have the rates of obesity. Nobody's homeless. Everybody's got childcare or maternity leave, early preschool, and universal health care. I mean, we'll have universal health care here when my Republican colleagues get mad enough at insurance companies that they're like, anything's better than this. And that might be coming soon. So I'm not, it's like apples and oranges. But in terms of what we can do, you're absolutely right about following all the recommendations. I'll leave that to the docs here. But the other one is if we lose Medicaid, the highest risk populations will lose any ability to get screening, to get blood testing, to get CGMs, to get pumps, to get insulin, and that will be disastrous.
I think like one thing that the American Diabetes Association has been really good about has been speaking up for marginalized populations. That we know diabetes is a group that there's a lot of at-risk populations, and with the current administration's attack on diversity, equity, inclusion to expand to things having to do with opportunities for all, we all need to speak out more too. It's a dangerous time too in the sense that the administration has been weaponizing the state with financial penalties, legal sanctions against different groups and organizations. So more than ever, we need to stay together, not be picked off one at a time like individual universities or individual media companies or individual law firms. It's an important role for the ADA in terms of collective action. And for all of us to think about what are our responsibilities, where we can be brave and as courageous as possible, and where we need to support each other too, because again, there's power in numbers in the collective, more so than as individuals. We need to support one another.
And I think one thing that you mentioned is this idea of, is it a cultural value or is it not a cultural value? And that's something that each of us can be part of, is having those conversations with our neighbors, with people who think differently than us, of really trying to shift the way we're thinking about spending on social services and addressing things that seem like outside of the purview of healthcare. So in that way, I would say this is a time to really lean into our values and lead with that, and not be afraid of having those conversations at a time when some of this is under attack.
One more question from the front microphone.
I'm Dr. Mohan from India, and one of the things which seem to be coming up very strongly is the cost of medication. And slides were shown where when generics came in, the cost dropped until there was competition, it was not there. In India, generics have been the ones which have saved millions of lives, because the original compound will be only taken by the top 5% of society, but the moment the generics come in, then it seeps down into the entire population. One of the slides, I think it was Namrata's slide, which showed 2036 as the date of expiry of Ozempic. I think it's 2026. I think it's next year, because our Indian companies are already getting ready with the generics of semaglutide, and we are told that next year we'll have all the generic semaglutide. So the moment the patent goes off, that is a big push for generics to come in. And then the prices in India at least drop by almost 80%. So, and then it becomes available. And I've seen how in your country also, when generics come in, it helps. So that's probably one solution for the very expensive drugs, for generics to come in. And some of the governments, of course, if it's a life-saving kind of a drug, even before the patent expires, they work with the companies, and some of the companies actually generously reduce the price and provide differential pricing. But I don't want to get into that. But even if you get into the generic situation, I think that's one big thing that can help you, as it helps our country. Thank you.
So I would fully agree with that. And to peg in back to the research side, part of my work is about where our drugs come from. And we have that concern that we depend a lot on other countries for our supply, right? And in the generics world, we depend, for example, on antibiotics. We depend on China. What are the national security implications from that? But I think relevant to this conversation is that by cutting research funds, we will be progressively also dependent on other countries for innovative drugs. And I think thinking about this from that perspective, that is not only about our clinical value, our quality of life, our health, that there's also this element of, until this point, we're at the forefront of drug development, and 100% of the drugs released recently into the U.S. market have benefited from federal funding in their development. So that is quickly shifting. We have China already spearheading many innovative drugs, especially on complex molecules. And is that something that our values want to support? Taking a step back and not letting other countries lead on drug innovation as well.
Okay, we're going to go 5 more minutes. I'm going to call on the microphone in the back, please. Keep your question short. Thank you.
Sure. Henry Rodriguez, pediatric endocrinologist, University of South Florida. I have the honor of actually following Francisco as chair of the National Advocacy Committee for ADA. So I would implore all of you in the room, your colleagues, anybody listening to this after the fact, to go on the ADA website, register as an advocate, and therefore you can hear about all the issues as they come up. ADA really does have an avenue for all of you to participate, grassroots, local, state, and national level. And so I applaud you all putting this together, this symposium for this morning. We all realize just how important all of this is. And so really the call of action is to get involved. And ADA provides that mechanism. So I'd encourage you all to go online. There's an advocacy update at the booth tomorrow afternoon. Pass by there, but go online, become an advocate, and get involved.
Thank you.
Thank you.
Answer questions. Thank you.
Al Powers, Vanderbilt University. First of all, I wanted to congratulate the ADA and specifically Diabetes Care and Dr. Khan and the Planning Committee for having this session. It was spectacular, right? So I can already see that I want to play this for groups of students and all of that sort of stuff. So great work, very important. And Dr. Schreier, thank you very much for being here for that. I want to ask Dr. Sokal a question because one of the themes here was competition will help. You know, I'm kind of old and I've got gray hair, and I'm not so sure competition and health economics go together. So I want to give you one example and ask you to compare. The drugs that are used for rheumatoid arthritis, Humira, there are like 8 different biosimilars on the market. But when you look at the use of those drugs, they're very low, where the brand name Humira. So that's an example where you have real competition and it doesn't work. So would you comment on that, please?
Very quickly, and thank you for this question. Well, I was only given 10 minutes, okay? But to summarize, we don't often use the product that would be making patients really better off and insurers better off, because we're allowing people to profit from these drugs. It's often called the rebate wall. It prevents drugs that are already in the market from being more frequently utilized. And I think that's part of PBM reform that we have mentioned, and it would significantly change these incentives. And I hope it will be adopted sometime soon.
I'll just mention a little bit about just like thinking big picture about drug development. So kind of the way we've done it for, essentially my lifetime is that NIH or, publicly funded science pays for the basic science that enables this. And then we use a sort of, windfall approach where because of the promise of earnings through patent protections, pharmaceutical companies can sort of do the clinical stage. And no doubt there have been a lot of successes in doing that, but there's a high price to that, literally, in that, you have to have these monopoly prices for a period of time in doing it that way. There are other ways to think about financing drug development, including extending the publicly financed phase into more of the clinical drug development phase, which has been very successful in the basic science world, and there's no reason in principle that it couldn't work as well. That would be a different approach to doing it, but I think it's one that's worth considering. And in particular, when the supposed advantage of the sort of windfall patent protection based approach is that it facilitates a lot of innovation. We also wind up having situations where, again, NIH research that has funded, essentially all the science that led to drug development in the last 40 years can be cut in half, sort of at a whim. That is very likely to stifle innovation as well. I think we need to think seriously about other ways of organizing our drug development process.
All right, Jose, quick.
Jose Flores from Mass General Brigham in Boston. Question for Congresswoman Dr. Schreier. From your vantage point, you've alluded that one of the rays of light was the bipartisan consensus when it came to supporting biomedical research in this country. So from your vantage point, what are the prospects for restoring that bipartisan consensus, and what can the legislative branch do when the leadership of the major agencies, NIH, FDA, HHS, is really dependent on executive power?
Okay, so again, this is supposed to be a nonpartisan discussion.
Sorry.
There is a time when, we have 3 branches of government. Congress controls the purse. We say exactly where we want dollars spent. We already said that. And this administration's doing a run around Congress right now. And so, the first thing I need is for my colleagues to stand up with us. Like, they know they've got partners with us. We will be there. We want robust funding for these things. So the first would be to stand up. And the second would be, when there's a run around Congress, for them to really push back on that, and for the court, they can take that to the courts. The third thing is that there is some element of this that we just can't control. Like, things they're not standing up. The courts are not limiting power. Like, things are just not happening in the way we need them to happen. And so we can keep pushing and pushing and making a case, but it may take 4 years to 3.5, who's counting, to get back to a place where we really invest. And I wish I could give you, I am hearing that conversations are happening behind the scenes. We just heard special diabetes program is getting funding. Like there is a overreach and oops that keeps happening. And so hopefully if we keep calling attention to the oopses, then we will bring this back even before there's a political change in the country.
Thank you. All right. I want to thank everyone. Thank you so much for joining us.